Dear colleagues, during my talk I would like to focus on the role of ultrasound and MRI in the primary workup in the management of cervical cancer patients. Let me introduce a few facts. There is enough evidence to emphasize that pelvic examination combined with biopsy is a method of choice to diagnose a tumor, but not to stage one. Because clinical examination is inaccurate to assess the tumor size in non-enlarged cervix, parametria or lymph node status, we should not burden the patient by examination in general anesthesia, and instead of that, the treatment decisions should be guided by modern imaging techniques. In order to assess the extent of disease in the pelvis, MRI was until recently the gold standard modality, whereas CT and PET-CT were inferior to document local tumor extension due to low tissue contrast, and ultrasound used to be used only as a screening method for hydronephrosis. However, it has recently changed. Ultrasound has undergone major technical developments over the decades, especially the development of endovaginal high-resolution probes allows to acquire a detailed view of the pelvic anatomy, similar to MRI. On top of it, the transabdominal scan provides us with the information on lymph node status and distant metastasis. Looking at these images retrieved from MRI and ultrasound, I would like to demonstrate the identical image quality of both techniques, enabling high tissue resolution. The combination of grayscale and color Doppler on ultrasound helps us detect the tumor and establish the tumor extent. As we can see in this video of the same patient with large tumor of mushroom-like appearance due to exophytic tumor growth, only involving the anterior lip of the cervix, whereas the posterior lip and endocervical canal are tumor-free. However, ultrasound can be used not only to assess the disease limited to the uterus, but also to assess the extension of tumor spread in the surrounding organs, as it is documented in these images, where tumor infiltrates the bladder and rectal wall. This is a video of the same patient. In the sagittal plane, we visualize locally advanced cervical cancer infiltrating posterior bladder wall on ultrasound. Both ureters are embedded within the ventral parametrial infiltration. Stents are inserted in both ureters. And here it will be shown the corresponding image from MRI. Now we will move to the transverse view. In the transverse view, the pelvic side wall infiltration is visible on both sides. It involves the obturator and piriformis muscle, and by moving the probe ventrally, we visualize the course of ureteric stents towards the bladder. The Foley catheter is within the bladder. It will be seen just now. The bladder is infiltrated especially on the left side as seen on ultrasound and the corresponding CT image. By moving the probe dorsally, we follow the ureteral stents embedded in the infiltrating pelvic side wall. We identify the infiltrated left uterosacral ligament infiltrating the hypoechogenic muscle layer of the sigmoid colon, and here you see a corresponding CT findings where the rectal wall infiltration is not visible in such details in comparison to ultrasound. An integral part of the assessment of disease extent in the pelvis is the evaluation of pelvic lymph nodes. On ultrasound, we combine the examination of endoluminal probe inserted either into vagina or rectum with transabdominal probe to assess the infiltrated lymph nodes above the interiliac bifurcation. This is a video of two densely grouped lymph nodes located in the left obturator fossa, clearly demonstrating using high-resolution endovaginal probe. As you can see, the infiltrated lymph nodes lost their typical architecture, becoming hypoechogenic, rounded, and with transcapsular vessels penetrating the cortex from outside. They are less visible using transabdominal probe since they are covered by acoustic shadows from the sigmoid colon. The first step to implement ultrasound in primary workup in cervical cancer was to provide the evidence of its accuracy in local staging. To assess the value of ultrasound in local cervical staging, we compared ultrasound with the gold standard imaging modality, which used to be pelvic MRI, and we use histopathology as a reference standard. The first study, which came from my department, has shown the comparable accuracy between ultrasound and MRI. The results were confirmed 1 year later by an Italian group. Based on single-unit study results, we initiated a multicentric European trial which became a basis for the implementation of ultrasound in the updated European guidelines on cervical cancer management. For the first time in history, ultrasound became a recommended alternative to MRI in primary workup in cervical cancer. At the end of 2018, the revised FIGO guidelines were published, allowing the use of imaging to assess the tumor size and disease extent. And FIGO recommends ultrasound as one of the methods of primary workup since it provides a comparable information to MRI for staging if performed by a trained sonographer. Why do we prefer ultrasound to MRI? Ultrasound is commonly available imaging method in gynecology, cheaper than MRI. It is also easier for patients since it requires no fasting or contrast agent. Ultrasound doesn't have radiation load and known contraindications for patients. Furthermore, an ultrasound scan can be carried out directly by gynecological oncologists with the added benefits of their knowledge of the disease. Although both methods have an excellent tissue resolution, the dynamic aspect of ultrasound has improved our diagnostic confidence in local tumor staging. The sliding effect is demonstrated in this video. By gentle pressure with the probe against the cervix, we may observe the sliding of cervix against surrounding tissue planes, which would not happen if there was an infiltration, as it is nicely visible in this case with infiltrated bladder wall by cervical cancer. To assess the local tumor extent on ultrasound, we insert the high-resolution probe transvaginally or transrectally. We prefer the transrectal approach in order to eliminate the potential risk of bleeding from protruding fragile cervical tumors. Transrectal approach also improves the visualization of exocervix and reduces the artifacts. Please note that we use the identical probe for transrectal scan, covered with gel and condom without need of klizma or fasting. Looking at these videos of transvaginal and transrectal scan, you can note that transrectal scan on your right hand offers us identical image quality. On the video, you can visualize the large cervical tumor infiltrating only the anterior lip of the cervix, protruding in the vagina. There is an intact endocervical canal and homogeneous posterior lip. First, we detect the tumor presence. On ultrasound, we visualize cervical cancer using grayscale and color Doppler. On MRI, we detect the tumor using morphological sequences recently supplemented with functional ones that include diffuse weighted images and dynamic contrast enhanced MRI. Areas of restricted diffusion of water molecules in tumor tissue appear bright, which correlates with lower ADC value. Lower ADC values are manifested as a darker shade of gray on the ADC maps. The dynamic contrast enhanced MRI is used to assess tumor angiogenesis, which is visible here as an area of enhanced signal intensity. In this video, we visualize cervical cancer on ultrasound using grayscale and color Doppler, and on diffusion-weighted imaging as a hyperintense area with corresponding lower value of ADC map and with enhanced perfusion within the tumor using the dynamic contrast enhanced MRI. Regarding tumor detection, in our multicentric study we have shown slightly better results of ultrasound to MRI, since we know how the different tumor histotypes look on grayscale ultrasound. Additionally, Doppler helps us establish the extent of the tumor. Cervical cancer is mostly squamous cellular. On ultrasound, it has a hypoechogenic appearance with high density of tumor vessels, as being demonstrated in this video. In this video, there is a squamocellular cervical cancer, which is manifested as a hypoechogenic rigid tumor with enhanced perfusion. While adenocancer is manifested as an iso or hyperechogenic tumor, less visible in many cases, but always highly perfused. This is a typical hyperechogenic adenocancer with hyperfusion and positive sliding sign. Applying a slight pressure with the probe against the cervix, we can observe sliding of the tumor against surrounding tissue, and therefore we can exclude their infiltration by cervical cancer with high degree of certainty. After we have detected the presence of the tumor, we measure its size in 3 diameters. As per the tumor size, both modalities have shown a very high agreement with histology in this multicentric study. In the multicentric study, the next step was to assess the depth of stromal invasion, which we classify as a proportion of infiltrated stroma to the whole cervix. And again, both modalities have shown very high agreement with histology in order to assess stromal invasion depth. And the last step to confirm T1 disease, in other words the early stage disease, is to exclude the parametrial invasion. In instances like this one, where the intact pericervical fascia is present surrounding the cervix, corresponding to hyperechogenic line on ultrasound or hypointense line on MRI, there is no infiltration of parametria, with negative predictive value reaching almost 100%. In our multicentric study, ultrasound was proven to be even better than MRI for exclusion of the parametrial invasion. The slightly better results for ultrasound may be related to the dynamic aspect of examination. Dynamic aspect can be useful in a situation like this one, with limited visibility of ventral parametria due to acoustic shadow, where the presence of sliding of a tumor against the bladder is a sign of negative infiltration of ventral parametria. In early-stage cervical cancer, the role of imaging is not only to assess the tumor size and to rule out parametrial invasion, but also to specify parameters crucial for individualized treatment, such as a cranial tumor-free margin, which is measured between the upper edge of the tumor and internal cervical os. As we can see, sensitivity and specificity of ultrasound and MRI is comparable in the measurement of a cranial tumor-free margin. Secondly, we assess a minimum uninvolved stroma, which is called a tumor-free distance. In reality, it can also be called a lateral free margin. It is measured as a remaining uninvolved stroma between the tumor and pericervical fascia at the point where the ventral, lateral and dorsal parametria are attached to the cervix. Looking at available evidence, ultrasound and MRI have shown almost identical results regarding sensitivity, but specificity was slightly lower for MRI. Looking at this video, I would like to demonstrate how to measure a cranial tumor-free margin in a patient with adenocancer requiring fertility-sparing treatment. First, we identify the tumor on grayscale ultrasound. We carefully exclude the presence of multiple lesions through visualizing the endocervical canal and endometrium. We carefully evaluate the endometrial cavity from right to left ostia by moving the probe inserted either within the rectum or in vagina from right to left side in sagittal plane. The next step will be switching to color Doppler to identify the upper edge of the tumor, and we measure the shortest distance between the upper edge of the tumor and internal cervical os. And then we measure the minimum uninvolved stroma as the remaining uninvolved area between the tumor and the attachment of right dorsal and ventral parametria. And then we measure the uninvolved area between the tumor and the attachment of left dorsal and ventral parametria in the longitudinal plane. Then we turn the probe 90 degrees counterclockwise to get a transverse plane, and we measure the uninvolved remaining stroma between the tumor and the attachment of both right and left lateral parametria to the cervix. In order to assess vaginal infiltration by a cervical cancer, we use a physical examination. Therefore, we will only focus on the assessment of parametrial invasion. As negative parametrial infiltration would be described a situation with intact pericervical fascia surrounding the cervix, or with disrupted pericervical fascia but not visible tumor projections through the fascia into the parametria. All other findings, such as the presence of continual or discontinual tumor growth, are assessed as positive parametrial infiltration. This is a case of an early-stage cervical cancer with no infiltration of parametria. In order to assess parametrial involvement, we use a systematic approach. We start in the sagittal plane in the midline view of the cervix. In the sagittal plane, we move the probe from midline to right lateral side of the pelvis. First, we display the vesicouterine ligament. By shifting the probe more laterally, we identify the lateral ligament of the bladder and follow the course of the right ureter from the trigonum through the lateral ligament of the bladder into the lateral parametrium. The ureter divides the lateral parametrium into its medial and lateral part. At the same moment, we can observe the right uterosacral ligament. It will be visualized right now with the hyperechogenic pericervical fascia. The same procedure will be repeated on the left side. We start in the midline position of the uterus by shifting the probe from midline towards left lateral side. First, we focus on the left vesicouterine ligament. By further moving the probe on the left side, we can identify left ureter and follow its course through lateral ligament of the bladder and lateral parametria. At the same time, we will identify the uterosacral ligament left. Now, we turn the probe 90 degrees counterclockwise and visualize the lateral parametria on the right side. The cervical vessels are running within the lateral parametrium. By moving the probe dorsally, we identify both right and left uterosacral ligaments and the rectum. Here we can visualize the posterior wall of the rectum. By moving the probe ventrally, we pass the left lateral parametria with cervical vessels within. The left ovary is also visible here. By shifting the probe ventrally in transverse plane, the bladder and ventral parametria, both on the right and left side, are visualized. We move to more advanced case. We start in sagittal plane in midline position of the cervix. By shifting the probe to the right side, there is a visible disruption of the hyperechogenic pericervical fascia. Please note the tumor projection from cervix into the echogenic fatty tissue of lateral and dorsal parametria. The color Doppler helps us to differentiate hypoechogenic cervical vessels from hypoechogenic spikes of tumor into parametria. After we visualize the dorsal parametria in the sagittal plane, we move the probe 90 degrees counterclockwise to visualize and confirm nodular infiltration of the lateral parametria in transverse plane. By moving the probe ventrally, we confirm the disruption of pericervical fascia. Please note a corresponding MRI image, which is located on your right hand. We move to a more advanced case. We start again in sagittal plane in midline view of the cervix. By shifting the probe to the right side, there is a visible complete infiltration of the right ventral parametria, with ureter embedded within the infiltration. The lateral and dorsal parametria are also infiltrated. The course of the ureter is recognized by an inserted stent, and here is corresponding MRI image, which will be on your right side of the monitor. We move from the right to the left side to display complete infiltration of the left ventral parametria and the wall of the bladder. The stent is also inserted in the left ureter. There is a nodular infiltration of lateral and dorsal parametria. Now, we will move the probe 90 degrees counterclockwise. For correct orientation, there is a bladder. We demonstrate the ureteric stent in both ureters, running from the trigonum through infiltrated ventral parametria. Here is the corresponding image from MRI. by shifting the probe dorsally and following the course of the ureteric stents, we identify infiltrated lateral and dorsal parametria. The right uterosacral ligament reaches almost the sacrum, but the rectal wall is not infiltrated yet. Even though the tumor is in close proximity of the rectal wall, there is still a positive sliding sign of the tumor against the rectum. This dynamic aspect of ultrasound examination is very helpful, and as you can see on the corresponding MR image, it is very difficult to exclude rectal wall invasion from the static MR images. By moving the probe ventrally, we demonstrate again the infiltration of lateral and ventral parametria. This is a case with intact pericervical fascia but discontinuous tumor spread within the left paracervix in the form of infiltrated visceral paracervical lymph nodes. We are in the left oblique plane visualizing the cervix and two rounded hypoechogenic, completely infiltrated visceral lymph nodes. The course of the left ureter helps to locate the nodules which are displayed in the medial and lateral part of the left lateral parametrium. On the color Doppler, the cervical branches of uterine vessels are visualized. In the right lower corner, there is a corresponding PET-CT image. In locally advanced cervical cancers, the tumors are usually not operated. In order to prove the accuracy of ultrasound, the ultrasound findings had to be compared to MRI. In the study initiated by Valentina Chiappa and other Italian colleagues, ultrasound nearly reached a very good agreement with MRI using kappa coefficient. Now let's move to T3 stage, characterized by pelvic side wall invasion, often accompanied by the presence of hydronephrosis. We distinguish three grades of renal dilatation. In a first grade, the dilation of the renal pelvis is visible. In the second grade, the dilation spreads into the calyces, and in the third, there is an atrophy of renal parenchyma due to pressure from the urine. I would like to demonstrate the findings of hydronephrosis grade 2 in a patient with an early stage cervical cancer with no parametrial infiltration. On this video, we demonstrate a grade 2 hydronephrosis characterized by renal sinus and calyces dilation. Using transabdominal probe, we can follow the hydroureter to the pelvis, crossing the common iliac vessels, and from there we can easily identify the possible reason of obstruction using the high-frequency endovaginal probe. By right pelvic side wall, we visualize distal part of the dilated ureter with vermiculation. The obstruction was caused by fibrosis resulting from deep endometriosis in retroperitoneum. Ultrasound is a very specific method to screen hydronephrosis. Lastly, cervical cancer often involves the adjacent organs in varying degrees. The extent of involvement in both the bladder and rectum can be determined simultaneously, and we grade the level of infiltration in both identically. In the upper video, there is a massive infiltration of the right uterosacral ligament. The sliding sign is still positive against the rectum, excluding the rectal wall infiltration. Here is a corresponding image from MRI, where it is very difficult to determine the presence or absence of rectal wall infiltration. The bottom image shows a negative sliding sign of a tumor against the bladder as a sign of infiltrated bladder wall. Furthermore, ultrasound or MRI can detect the depth of bladder or rectal wall invasion, so cystoscopy or proctoscopy should only be performed in indicated situations. Lastly, the assessment of pelvic lymph nodes belongs to the primary workup as well. As far methodology, we position the probe laterally to the cervix and follow the cervical branches of uterine vessels towards the internal iliac vessels, all the way up to the interiliac bifurcation. Now, the obturator artery will join the internal iliac artery on the left side. The bifurcation of the left internal and external iliac veins will be visualized close to the bifurcation of the left external and internal iliac arteries. Looking at this algorithm, the role of MRI or ultrasound in the primary workup is to triage patients with early stage disease and negative pelvic lymph nodes to primary surgery. In such a situation, the surgical staging of lymph nodes is crucial to detect micrometastasis or small volume metastasis. While locally advanced cervical cancer or early stage disease with positive lymph nodes will be treated with primary chemorad or palliative chemotherapy. Do we have evidence of ultrasound ability to detect pelvic lymph nodes? Recently published meta-analysis has shown that ultrasound is the second most sensitive method after diffusion-weighted imaging to prove the negativity of pelvic lymph nodes, but the sensitivity of imaging is still not sufficient enough. On top of it, ultrasound is the most specific method in terms of lymph node positivity detection. With the use of high-frequency endoluminal probe, we are able to identify the sonomorphologic and Doppler patterns of infiltrated lymph nodes, which will be demonstrated using a transrectal scan in the following video. On transrectal scan, we display cervical cancer between the left ovary and the left external iliac vessels. We can find a hypoechogenic rounded infiltrated lymph node located in the left obturator fossa. If we magnify the image using color Doppler, we demonstrate transcapsular vessels penetrating the cortex from outside. The transabdominal probe identifies the infiltrated nodes in the higher levels, above the interiliac bifurcation. In this case, another large node is found compressing the left common iliac vein. However, the hyperechogenic tissue between the node and the vessels is still preserved, which is visualized right now. In case of locally advanced cervical cancer, we also need to assess areas outside the pelvis to rule out disease dissemination. And for that purpose, the whole body CT or PET-CT is recommended. It is worth mentioning that there are heterogeneous data regarding the routine use of PET-CT in locally advanced cervical cancer. In the meta-analysis of 2010, CT and PET-CT have similar diagnostic performance when assessing metastatic lymph nodes. Therefore, in locally advanced cervical cancer staging, chest and abdominopelvic CT is recommended, and PET-CT is the preferred option before definitive chemorad, as published in the updated European guidelines. European and international guidelines recommend incorporation of imaging in the assessment of tumor size and disease extent. Based on technical improvements of ultrasound devices, ultrasound has become an effective alternative to pelvic MRI in primary workup in cervical cancer patients to detect disease extent in the pelvis. In locally advanced cervical cancer, to assess extrapelvic nodal and distant metastasis, CT or PET-CT is the method of choice before definitive chemoradiotherapy or palliative chemotherapy. Thank you for your attention.